Hello, everyone. Happy Friday. Happy Valentine's Day to all of you who celebrate, which I hope is everybody, because I think there's nothing as special as love. And in fact, that's the middle name of this entire venture. So happy Valentine's Day, my love, Prof. Rez. Uh, yes, we
Dude,
flirted.
as you said that, I'm reaching to my phone to text Liz.
Tell Liz that I wished you first. Um, it is a day of course, celebrating your relationships, but also the platonic loves that you have, including mine, Prof. Rez, but also for this wonderful space, the CP Solvers Academy. And today, a special gratitude to everybody who's involved. It's yet again an all internal affair. Let me hand the mic to Gerardo to say hello, who is scribing today.
Hello, everyone. My name is Gerardo Luna. I'm a medical student and I'm in my sixth year. From Peru and I'm very excited for Rahul's case. Yeah, I'll pass the mic to Casayar. Um, and yeah, I love your hair, actually. Your hair is outstanding today.
My
Thank you.
Latina and Kashar's extensively beautiful hair. What's new, Kashar?
Okay, I'm embarrassed now. Thank you, everyone. I'm Khashar, medical student from Iran, one of the CP Solvers Academy members. Glad to be back. I haven't really been attending the past few weeks, but yeah, excited for today.
Gonna be a lot of fun, Khashiyar, because Rahul is presenting a case that he did not see but worked hard to put together. Rahul, um, I would love to. I know that you will tell me like you did last time that you live a very simple life, and that if I ask you a very high frequency, high pitch enthusiasm question, Prof. Rez will make fun of me and remind me that Rahul is a gentle human being. So instead, I'll ask you a very specific question, my friend. Can you tell us what delicious food you were having this morning so everybody else can benefit from it?
Absolutely, Rabi. And it was crispy corn. My aunt bought the corn directly from the crop. I mean, from the market, and we thought of making some kind of evening snack.
Hmm.
And we went to the YouTube, and we really don't know how to make it because it's like purely restaurant thing. It's not a homemade food. And we tried it. It turned out very, very well. It was delicious. It was
It
crispy
looks
corn.
so good. You know what I thought of? I wanted to save this moment because the moment you showed it to me, the moment I thought if Prof. Rez could put that corn on his Chipotle burrito, I think he would find heaven. It looked so good. So thank you. That's not the only delicious thing you have for us today. Another amazing case, I'm sure. So we managed to keep Prof. Rez silent for 7 minutes, but why don't you start off with the first aliquot so we can finally hear him wax poetically.
Absolutely. So coming to the first aliquot, the chief complaint is a 44-year hospitalized woman. She was a hospitalized woman, and we were called by the nurse for fever. Coming to HPI, patient was admitted 3 weeks ago for fever with bilateral costovertebral angle tenderness and found to have an ESBL pyelonephritis treated with levofloxacin. On her admission, CBC was incidentally found to have a marked leukocytosis in the range of 90,000 with a 70% of blast and anemia thrombocytopenia. And subsequent and hematology was on board, and they did the bone marrow biopsy that revealed acute myeloid leukemia and was started on induction chemotherapy 2 weeks into her hospital stay with 7+3 regimen, which includes citrabine and idarubicin. 3 days after starting chemotherapy, she developed progressive pancytopenia, felt to have most likely thought it could be from chemotherapy related, and she was receiving intermittent transfusions. And 5 days after receiving the chemotherapy, she developed a fever of around 38.7 degrees Celsius. During that time, nurse paged us because of this concern. So this is the end of my first aliquot. I'll stop here.
I just have to say, oh, well, good morning, Rahul. And good afternoon or good evening. What time is it there? Let me get this right.
It's 10:40 p.m.
Okay, good night. Bonne nuit, bonne nuit. I have to say this, that I'm just so impressed by you guys. Really, like, you guys have taken the presentation of cases to the next level. Like, to give all this data, knowing that this case has a lot of twists and turns up front. I just want to applaud you, Rahul, and the other team members, because David recently had presented a case, and similarly, I was just astounded at how he took a complicated case and presented it in such a streamlined fashion. And I have to say a good morning, good afternoon, good evening to all the YouTube listeners. Happy Valentine's Day. How are you guys doing? Let's chat for a minute.
That sounded like a little evil laugh, Prophet.
You know how sensitive I am to their comments, Robbie. I had to establish a good relationship with them. Maybe what I'll do is I will tackle how do we deal with an evolving presentation in the hospital and then leave the fever and the rest of the thoughts to Robbie to discuss. But anytime someone is hospitalized and develops a new symptom, it's so easy to be caught off guard and make a diagnostic error. Think about it. There's been so many times I've been in the hospital, someone has chest pain, someone orders an EKG, but that EKG is never followed up on. Why? Because when they're hospitalized, we sort of are trapped and anchored into their initial diagnosis. And it's so easy to dismiss subsequent symptoms or signs that may develop. Now, contrast that to someone who comes to the emergency department where you have your ED hat on, you're constantly thinking, what is driving this presentation? So how do we prevent falling into a trap of dismissing someone's finding? I honestly tell myself, like, let me pause and think, what if the patient was presenting with this new finding? Like at index presentation, how would I tackle it? So whenever a symptom develops in a hospitalized patient, the natural question is it an evolution of their initial presentation? Is it completely unrelated? And that's where you have to say, hey, let me just play and think, if this were unrelated, how would I tackle it? Or is it a complication of therapies or the hospitalization? And let me give you an example. Someone comes in with pyelonephritis like this individual, and you start treatment, and then they develop a fever a few days after initiating the appropriate antibiotics, because here we have a targeted organism. The next question becomes, well, naturally, is this a complication of the pyelo? Do they now have a paranephric abscess? Do they have emphysematous pyelonephritis? Or is it completely unrelated? And this was a patient with dementia who now has aspirated and in fact has a pneumonitis that's unrelated to the pyelonephritis. So I think the setup for a patient who's hospitalized like this patient is this a progression of one of the two underlying diseases? Is this a complication of a therapy that the patient received? Is this unrelated, or is this a process of both the complication of the therapy they received and their underlying disease entity? So with that framework, I'd love to give the mic to Robbie to, actually talk about the case rather than a hypothetical framework. Happy Valentine's Day, my love.
Oh,
By the way, Liz thanked me and said, hey, I love you. Next year's going to be better. I didn't even know today was Valentine's Day. But fortunately, Liz doesn't listen to these episodes, so I am in the clear.
all right, all of you, send that episode link to Liz.
Oh, you better.
So, Prof. Rez, that was a beautiful 10,000 review, and it really allows us to make progress on the situation that we have. And I think the situation that you have right now is you have to understand that it's a medical emergency. There are only a few times where a fever alone triggers the evaluation for a medical emergency. And the two situations I can think of off the top of my head are fever in a patient with cirrhosis, which often triggers high risk for subsequent decompensation, and then fever alone in a patient who has no neutropenia. Absent those two circumstances, fever alone usually means that the patient has inflammation, and you can take your time to figure that out. But the risk of the fever heralding something disastrous in a patient with cirrhosis or neutropenia is so high that actually an empiric, thoughtless protocol is instituted robotically. And what is that empiric, thoughtless protocol? Collect the diagnostic information that you can readily in the next 5 minutes as quickly as possible without getting antibiotics. And as soon as you've collected the blood and urine, give antibiotics. That's how high stakes this is. So the nurse pages you with this. Before you need any other information, what you're going to ask is to collect the blood cultures, get the urine, and then give antibiotics. After that, you're going to have to be thoughtful, but only thoughtful after you've instituted empiric antibiotic therapy. What empiric antibiotic therapy? Gram-negative coverage in everybody, usually cefepime. Gram-positive coverage in people who are at risk of gram-positive infections based on the presence of indwelling lines, the presence of a skin and soft tissue focus of disease, or pneumonia. And then you have to think. And here's the problem. Sometimes when you act robotically, you think you're done after you execute those robotic steps. You're like neutropenic fever, blood cultures, chest X-ray, UA, cefepime plus minus vancomycin, full stop. But that's not the landscape. That's the robotic response to neutropenic fever. But what if the patient has something else going on? Meaning neutropenic fever plus recent pyelonephritis, or neutropenic fever plus right lower quadrant abdominal pain, or neutropenic fever plus right first toe pain. So the next step after you execute the empiric life-saving therapy is to ask what else is going on in this patient in neutropenic fever and how does that alter my workup? And in this particular patient, given the focus of ascending pyelonephritis in this patient, the momentum by which you're going to pursue that as your focus of infection is going to be very high. So what would I do based on this alone? Blood cultures, urine, antibiotics, broad set of labs. And because I think I'm going to need a CT scan of the abdomen and pelvis with contrast because of the recent pyelonephritis, I would order that, just skip to a CT chest because the patient's going down there anyway. And at the same time, while I put all those orders in, go examine the patient, look at the vital signs, and examine her head to toe, everywhere. A small focus of a soft tissue abscess on the buttock hidden from view because of pressure-related skin changes may be the source of all this discomfort, and I wouldn't want to miss it. So neutropenic fever is a medical emergency you have to treat before you think, but don't forget to think. All right, Mike to you, Rahul.
I loved both of your discussion, the emphasis on pyelonephritis and abscesses and your robustic management of neutropenic fever. And let me go on to the next aliquot. So we go and we go in to see the patient, and besides the fever, the rest of the vital signs are stable, and she has no cough, no diarrhea, headache, runny nose, sore throat, abdominal pain, or dysuria. And blood cultures were sent, and additional workup is ordered, and vancomycin and cefepime is started. With regards to other history, she has a past medical history of type 2 diabetes, and she's on insulin. And per surgical histories, no other surgical histories. And medications, she's on insulin, acyclovir, fluconazole, because both of them started because she became neutropenic. And she was on the chemotherapeutic drugs and the other antibiotics, as I mentioned, the vancomycin and cefepime. And there are no known allergies. And the family history, there's a history of diabetes in the family. And social history, she's from Mexico originally, but although she stayed most of the life in the western part of the US and relocated to the Houston 1 year ago. And there is no history of recent travel, no tobacco use, alcohol, or any substance use, and she is not currently working. So this is the end of my second aliquot. Let me stop here.
I think this aliquot is incredibly important for one reason and one reason alone, which is that now the range of possible infections that could be occurring is much broader. And I think that when we think about infections, everything that we just discussed in the first aliquot is all related to things that live on her body that take advantage of the fact that her immune system is compromised. Gram-negative rods from the GI tract, skin and soft tissue organisms. But there could be other things in her body that we don't know of. Latent tuberculosis, as an example, or an infection transmitted to her accidentally by transfusion, which Prof. Rez taught me a long, long time ago with an incredible case of babesia that he had in a patient with sickle cell disease. So I think we have to be very, very vigilant to the possibility, given this patient's residence in areas that are endemic for granulomatous infections, that we keep that not right in front of our eyes, but in our back pocket. Yet another reason now to scan her chest is to look for foci of granulomatous infection. But it's really, really important to have a mental checklist of common infections that can be reactivated in the face of immunosuppression. All the granulomatous ones, hepatitis B virus, and strongyloides hyperinfection. So all those things are in our back pocket should the patient continue to suffer despite treatment with pyogenic bacterial organisms and, of course, the elimination of the focus of pyelo that Prof. Rez outlined earlier. So very, very important to know the context with the patients. And any other thoughts, Prof. Rez, before we hand the mic to Rahul? All right, mic to you, Rahul. You can bamboozle Prof. Rez with the rest of the data.
Absolutely. Thank you so much, Ravi. And coming to the vitals, she has a temperature of 101 Fahrenheit and pulse rate of 95 beats per minute and blood pressure of 130/70, respiratory rate of 14, and she's saturating around 100% on room air, and the BMI is 27. And general exam, she's alert and oriented, and hint exam, HE hint exam, she's anicteric and mucous membranes are moist, and there are no evidence of any oral lesions. Neck exam, cardiovascular, pulmonary, GI, neuro, musculoskeletal, everything is normal. And let me give some labs. She has a white count of 0.4, the neutrophil count of 50%, and hemoglobin of 7.9, and platelet of 15,000. And she has normal BMP, and albumin is 2.8, total bilirubin of 0.7, ALT of 14, AST of 13, and alkaline phosphatase is 100. Let me give some more labs. And she is HIV negative and quantiferon gold negative, COVID, flu, respiratory syncytial virus negative. Chest X-ray is within normal limits. Urine analysis is normal without evidence of hematuria, pyuria, or proteinuria. Let me stop here.
This is really helpful, Rahul. I think, yeah, I think the group got all the data that you presented. Whenever we're approaching a patient with fever, and now we have confirmed severe neutropenia because the neutrophil count is 200, something I have to say that's really important is that this is just a spot evaluation of this patient, meaning that tomorrow when Rahul maybe checks labs again, the patient may have no neutrophil count. Oftentimes these patients are on Neupogen and they should be continued on Neupogen. And that's a way to stimulate the marrow to produce the granulocyte colony-forming units. As Robbie mentioned, as we're dealing with fever, we try to find a sign on physical exam or a symptom on our history. And really, we didn't find much in this patient, but you have to be very cautious and say, hey, because we didn't find much, there can't be an underlying pneumonia, or there can't be an underlying inflammation of the colonic tract. Why? Why do I say that? Because in order to have the symptoms, you really need an inflammatory reaction. But what if the patient doesn't have an immune system to stimulate an inflammatory reaction? Think about those patients who ultimately develop iris after antiretroviral therapy. It's because you've awoken the immune system to target those organisms that are hiding. So the physical exam would be useful if it were positive, and the symptoms would be useful if they were positive, but their absence doesn't negate the possibility of some sinister infection that might be brewing. And as I mentioned, the white count is 400, 50% is neutrophil, so that's 200. Anything less than 500 would be classified as severe, but I just, again, want to caution you that this is just one spot measurement, and we don't know how the trajectories are. There's another really important point that Harry Hollander has taught me and Robbie. How useful are antibody tests in someone whose immune system is shut down? So Rahul said the HIV is negative. Antibody, the quantiferon gold is an antibody test. It's not that useful, meaning that you have to be cautious with serologic studies in an immunocompromised host. So this is a 44-year-old, recent diagnosis of pyelo, probably was vulnerable because of the brewing AML, making her functionally immunocompromised, who then got started on treatment for levofloxacin, diagnosed with AML, and now has a neutropenic fever with no localizing signs or symptoms. And that's really all I wanted to mention here, Rahul, is that you can't interpret the serologic studies, and you really can't rely on the symptoms or the signs in someone who has such severe immunocompromised state. Really, you got to dig deeper, have a lower threshold for diagnostic studies, specifically the ones that Robbie had requested in the previous aliquot, and that's the CAT scan, because that will be so enlightening as to what might be occurring in this patient. And at this time point, we have to prioritize infections. And then after that, we can like broaden the DDX. But remember, she is getting immunosuppressed, so cancer is unlikely to be on that DDX. Autoimmune is unlikely to be on that DDX. It really becomes, what infection are we dealing with here? Robbie, anything else to layer on?
Poetry, Professor. I absolutely love that. Thank you. All right, Rahul, what do you have next for?
Sure. Thank you so much, Reza. I mean, I really loved the antibody, the pretest probability, especially in severely immunocompromised patients. I'll definitely remember that if whenever I order the investigation for the next time.
Rahul,
you so
you're too kind. You already know all of it, but you're saying that you're saying kind words. I appreciate that, my friend.
Let me share my next select what. So unfortunately, the patient fevers are continuing despite an antibiotic therapy, and over the next couple of days, she develops multiple tender erythematous papules and plaques with some scattered pustules on the anterior chest that spread centrifugally to the upper abdomen, bilateral upper limbs, neck, scalp, and ears. Let me show the image for you. Can you guys see the image? Yep. So these are the
Oh,
multiple.
sorry, Rahul. I can just see it's about to show, but it hasn't showed yet.
One second. One second.
Okay. All right, now we see them.
Can you see it, Ravi, now?
Yes.
Perfect. Thank you.
Yeah, I think your description is perfect. Yeah. Fascinating. Okay.
Perfect.
Okay, thank you so much, Rahul. I'll take a crack at it, Rafrez, but I'd love to, I think that whenever you see nodules like these are deep and they're painful. I think you can really come to the conclusion that the process is a deep one. And I think a very simplistic approach to a nodular rash is to really ask yourself first, what's the center of gravity of the disease? And I think that in somebody who has a systemic presentation here, fever, cytopenias, and has nodules, the overwhelming probability is that you're dealing with something metastatic to the skin and metastatic to the dermis, and that's why it's so deep. And so then it becomes a very simple exercise of what kinds of things metastasize to the skin. And the truth is that in the world of infections, it's almost always a granulomatous infection. So you might see crypto, blasto do this. And then some molds. The mold to really keep in your back pocket here is fusarium. Fusarium has a profound tropism for the skin and has some very devastating ocular and pulmonary consequences. So in the world of systemic diseases, infections, granulomatous diseases, and molds, cancers very rarely metastasize to the skin with one exception. And I think that exception, unfortunately, is leukemia cutis. So skin presentation of leukemia. And then, of course, the lymphomatous cousins, of which T cell lymphomas are more likely than B cell lymphomas. So I'll just lay out the framework for what I would be thinking about now, which is nodules, local versus systemic. Systemic priority is always given to infection. But in a patient who has leukemia, you would definitely think, okay, is this leukemia cutis? Now, why is that latter thought important to think about? Is because you might have to go bonkers treating the leukemia cutis, because it would mean that it is breaking through chemotherapy. There are great examples of local diseases and also some important autoimmune diseases, but I'd love to see what Prof. Rez, like what you think of the infectious and cancers, anything else that you're thinking of? And then also, if you're inclined to either authentically now or maybe later to elaborate on any autoimmune or anything else.
Yeah, no, dude, I love the point you made, Robbie, saying that, look, it's nodular, it's got to be deep. And we're pretty much applying the same framework as we applied initially, which is this just a progression of the underlying disease, here now being cancer instead of pyelonephritis? Or is this something as a complication of the therapy that we gave to the patient? And I don't know, but my gut tells me that this is more likely a complication of the therapy, like probably 70-30, and I'll explain why. Because when she first presented and had pyelo, got antibiotics, felt better, then ultimately got diagnosed with AML, really fever wasn't part of that presentation of AML, and then got the chemotherapy. So now I'm using the sequence of events, and it was subsequent to the chemotherapy that she developed this sort of, presentation. And so my question becomes, is it the drugs themselves causing some kind of reaction, or is it a sequela of what the drugs caused, here being neutropenia? So I'm still chasing infection, but I love the comment that Jazz made. I don't look at the chat often when I discuss, but every now and then a comment pops up. And Jazz made the comment of, could this be sweet syndrome? And I think whenever you say the word pustules, while we saw really papules, but if there were pustules, you really got to entertain the possibility of like a neutrophilic dermatosis. And what is sweet syndrome? Really, it's that neutrophilic dermatosis. It causes an inflammatory reaction. There might not be a trigger, but in this patient, we would be looking for an underlying trigger. And so, Robbie, authentically, what I'm doing now is I'm asking the question, is there any other sites that have evidence of metastasis, metastatic infection? Because if we get this CAT scan and it shows multiple pulmonary nodules, then I would, think, do we have a fungal infection that now has metastasized to the skin? If we get the CAT scan and we show nothing happening internal, and this is just all cutaneous, then I would be like, is this some immune-mediated neutrophilic dermatosis from the underlying cancer or Neupogen or something that the patient has received? So I think for me, the branch point is whether this metastatic process expands beyond the skin, or better put, expands beneath the skin. But let me give the mic back to you, because I know you were having some thoughts. I would love to hear, how are you balancing, like,
How could you hand me them? You just ruined your epic comment. Hold on, I'm just gonna try to do it again. Does it extend beyond the skin, or does it extend beneath the skin? Mic to you, Rahul. That's the only thing I would change.
Loved it. Thank you so much.
That was amazing, Prof. Rez. What am I gonna add to that? What am I gonna add to that? That was awesome.
You're extra nice to me, huh? I wish every day was Valentine's Day on Friday. I get this treatment from you.
All right, so let me go back to the case. And blood cultures reveal no growth, and fevers are continuing. It's spiking up again, and sometimes she remains stable without having other symptoms. And urine culture came back negative, and cefepime is brought into meropenem, and topical steroid was was started, but there was no much improvement, and dermatology was consulted. And for biopsy, and the no bacteria, fungi, or acid-fast bacillus seen on pathology stains or from the culture sent from the biopsy, and the staining from CMV or EBV came back negative. So I'll stop here and I'll stop here.
Yeah, Raul, this is really interesting data that I'd love my partner in crime to discuss. Robbie, John, where do you go from here, man? Like where biopsy, everything is negative. How do you interpret this?
Yeah, I think that what's going to be really telling here, Prof. Rez, is what the biopsy results were, what the primary abnormalities were. But I think that you would I think what would happen is you would really see if I think you'd probably take a leap of faith and say, hey, I wonder if the biopsy results there's a dense neutrophilic infiltrate, and that there's an operating assumption that you're dealing with a sweets or sweets-like pathology, which you would make based on the fact that this is a very great clinical context for that, but also because topical steroids were considered for the patient. They can read into what experts are thinking about this. And I think that the difficulty with the rendering of a sweets diagnosis is what sweets really is just saying that the patient's immune system is gone crazy. And the question is why? And the truth is that most of the time, in patients, in all comers, we don't know why. And we say it's because of a certain medication that they have, or a post-viral process, or maybe because pregnancy and the immune system and pregnancy, or IBD, so on and so forth. But I think in this context, it's really important to ask, are there specific questions associated with reactivation of stills? And the answer is absolutely yes. So all the granulomatous infections can actually trigger sweets-like physiology. So for me, I keep messing stills and
Dude,
sweets.
for a second, I thought, did I miss stills again?
No.
Because I've been told, like, you chart me. I was like, once again, like this, there's a certain diagnosis I'm always missing. Thyrotoxicosis, stills. I was like, wait,
Not today, Prof. Rez, not today. I think if we miss anything, we miss sweet. But I think it would be a big, big mistake to assume that this is idiopathic steroid responsive sweet syndrome until you fully exonerate all the infectious causes and you fully exonerate the possibility of leukemia cutis triggering stills. So the real life question that I think would be facing people, assuming the biopsy results don't show something else that would reveal the answer. So the biopsy results show tuberculosis, or the biopsy results show leukemia cutis, you're done. But if the biopsy results show a non-specific dense neutrophilic infiltrate, which I suspect it would, then it would be very, very tense situation. Because if it really is stills, then you would give steroids to the patient, but you would do so at the risk that you've missed leukemia cutis, and you would do so at the risk that you missed a granulomatous infection like tuberculosis that is actually the driver for all this. And so herein lies a very difficult tension. How much data do you need to be convinced to start steroids? And I think that the most you can do is a high quality skin biopsy, and to make sure that there isn't a focus of infection in the chest. And I think if the biopsy doesn't show leukemic cells, doesn't show organisms, and the CT chest is clear of disease, then the only thing you'd be missing, I think, is fusarium, which would involve the eyes. And so I would then probably say, okay, you know what, let's try steroids. And if the patient gets better, okay, good. If the patient doesn't get better, then we've missed something. So this is all a question of risk tolerance. How much risk are you willing to take on before you try steroids? And once you try steroids, you have to wait. So there's no way that anyone can tell me and convince me, because I'm a little bit conservative, that this patient has Still's disease, oh my God, Sweet's disease, until you both find nothing else, and you give the patient steroids, and they get better and don't get worse. That's how much it takes. And so I think you have to be very, very careful in this circumstance. So Prof. Rez, after that, fudging that horrifically, any other thoughts or reflections you have?
No, that was brilliant. I love what you did there. Not only did you say if it is even sweet syndrome, you have to look for a trigger and then how you emphasize even the treatment for it is a diagnostic test, and saying that, you know, that tension of like, when do we actually start the treatment? For you, the threshold is making sure there's nothing in the lungs that would suggest a foci there that's, you know, potentially traveling to the skin or triggering what's happening in the skin. I think that was really just beautiful, man.
Happy Valentine's Day, Prof. Ren. Poor Rahul. He's like, why did I decide to present today of all the days?
No, it's my pleasure. No, it's my pleasure. Yeah, the great discussion. I really loved your thoughts. And I'll share the next details, and after that, it reveals the final diagnosis. And let me share the further biopsy findings. And the pathology was, and the showed without evidence of leukemic invasion. However, neutrophils were seen in the dermis, and upper dermis was edematous with scattered macrophages with reactive fibroblast. With this, a diagnosis was made and the treatment was initiated. And the next report will reveal the diagnosis.
Yeah, Rahul, that was really helpful, expertly presented case. And I think one other main point that Robbie made or alluded to was that whenever you get a biopsy result, there's like three possible outcomes. One is you get a confirmed diagnosis. The other is you get, you know, not enough tissue or it's an inadequate sample. You really don't get any diagnosis at all. And then the third is more of like an equivocal state, like maybe it's this, maybe it's that. And I think what this biopsy does, it definitely confirms that there's neutrophils. That in itself is not diagnostic, I think, of a specific etiology like SWEET, but it's suggestive, highly suggestive. Then you get macrophages. And then if you ask the question, what are granulomas? They're basically macrophages surrounding an antigen. That's what they are. And so you may pause and say, hey, could there be granulomas? But usually the pathologist is very specific that, hey, we have granulomas where you have like these sort of macrophages surrounding an antigen. So Robbie, I love to hear from you because you started this thought. It seems that the pathology results are suggestive of SWEET syndrome. They didn't find any source of infection. And the patient's really not having pulmonary symptoms. So maybe it is time to take that leap of faith and say, hey, this is SWEET syndrome in this patient, and let's try the steroids. You know, they probably have an unknown trigger or their underlying cancer or a medication that they received, and we're seeing the sequela of that. I would love your thoughts. I'm not as well versed in that space of SWEET syndrome.
I think your thoughts couldn't be sweeter, Prof. Rez. I'm right there with you. I think this is just a threshold of how comfortable you are. I think the key thing to realize is that you do not close the door on the diagnosis until the patient gets better. And that sometimes steroids are used to really help. If you really got nothing else left to do, what other options do you have? You can just like keep watching this person, but either repeat some tests or just wait. And so I think in a well-described circumstance, I think we've reached my threshold to start steroids, but definitely not to call it sweets until we've proven that the patient gets better. So what happened, Rahul? What did you all do?
You guys are 200% right. I mean, everywhere the chat is also 100% right. And with the ongoing fever, with the presence of tender rash, with neutrophilic infiltration of biopsy, a diagnosis of SWEET syndrome was made, possibly from AML, and she was started on prednisolone therapy, initially starting at 50 mg and was slowly tapering, and then she has no more fevers, and rash was completely resolved within 1 week, and she was discharged 2 weeks later after improvement in blood counts. And yeah, so this is how the case turned. I just want to thank Alec first, because he's the one who saw this patient. And yeah, so thank you so much, Alec, for giving me this opportunity to present. And it's an honor and this is the first time I'm presenting this case to both of you on Friday. It's a pleasure and honor to learn a little from you today.
Oh my gosh, we got a hand raise. Raul, thanks so much for this presentation. It was incredible. I thought you synthesized the case epically. It was very sweet and thorough. And we have a hand raised in Jazz. Maybe Jazz, you can make your comment and then pass the mic to Robbie.
I just wanted to share my own experience in this. Like the reason why I was able to pick it up. Again, I loved Robbie's discussion here. Like, it's not sweet until you see the treatment response. And I just want to pose this out there to anyone who thinks that maybe clinical problem solvers might be, only for rare cases or whatever. I'm now reaching a slow point where, and this is for all the YouTubers too, where I'm like, wow, that's such a strange coincidence. And I kid you not, I had a case 4 months ago that was almost exactly the same case as this one. Almost exactly the same case. And then that patient, initially, infection workup was all initially negative. The patient was getting spikes of fever. Okay, he came in with this rash on his Mediport and his IV site. We got concerned for pathergy, no concerns for Behçet's. Then the hematology team starts the Granix. He starts to have fevers every other night. Before the Granix, he never really got the fevers. So initially they were thinking, okay, the Granix probably led to sweet syndrome. No, because he never got Granix when he started getting his chemo outpatient for his AML, and that would not explain the pathergy response. So that happened before. So it was such a great case. I was actually thinking of presenting it, but like Rahul's case was just as great. And like, I just wanted to share that. Like, that's why I got suspicious. And it's actually, even though it's a rare condition, it's not that rare. And I don't know what Rahul mentioned, but in our patient says they usually respond within 72 hours of steroids. And that patient, after 72 hours, his rash just melted away. It was really impressive. Fever's gone. And the last thing I'm going to share is our patient had an ANC of 0 when they first came in. And that tells you that you do not need to have a neutrophil on the diff to say that this patient has a neutrophilic dermatoses, because you'll always have circulating neutrophils that will go into the skin where the pathology is. So I had to take over the RLL, but I really wanted to share that and really emphasize that if you start seeing cases and practicing cases like this, you're going to see it in real time. It's just a matter of time.
That deep dish pizza in Chicago has nourished your brain like no other. Prof. Rez, this guy took his wonderful wife to Chicago for one reason: deep dish pizza. That's it. And now look how smart he's gotten. That was amazing. That was so good. And I couldn't agree more with that sentiment. I think the sum total of all rare diseases is actually pretty common. So there are so many rare diseases out there that maybe once a day you're going to bump into a rare disease, one of the many rare diseases. And the truth is that, like, yeah, I completely agree with you. I think that as Prof. Rez has emphasized before, VMR tends to be a place where we do encounter less common diseases. But if you look at what Prof. Rez started and taught all of us today, the first thing he said was a fundamental approach to a hospitalized patient who is not getting better. Now, tell me if that's common or rare. That's probably the norm for many, many people. And in fact, I'll tell you that there is an even more powerful momentum within the CP Solvers Academy, which all of you listening are invited to join. All it takes is showing up here, making an impact, making your presence felt, and you too can become Rahul, Jas, Gerardo, or Khashar. There's nothing to it but just showing up. And in that space, we talk about the bread and butter. Today, these poor souls at 7 a.m. were subject to a very fundamental talk about acute hypertension, something that'll be bread and butter for you all. So I really appreciate you making the point, Jas, that this is really all that we do here is things that people are going to see. There is no such thing as something too rare for somebody not to face it. I don't have anything to add to the reflection on the case. I think you nailed it so well, and just want to thank Prof. Rez. He didn't want to say this, or he didn't say this to you all, but he showed up despite being fairly under the weather. So really, really appreciate you, Prof. Rez, for powering through and enlightening us. I don't think we would have enjoyed it half as much without you or Rahul today. So thank you both. And I'll pass the mic to Khashar for the teaching points.
Hello, Robbie. I have one. I just want to share some of the teaching points for the point. So is it okay if you have time so that we can do it? I can show some.
Time is made for you, my friend. Unless Khashar feels strong. I'm kidding. Of course, Khashar will give you time. Take it away, my friend.
I think no more than 5 minutes. I think it will be done within 5 minutes. Let me show the fever patterns first. Can you see the screen? Yeah. So this was a fever pattern, and once we started the steroids, and the fever went trending downwards. Yeah. And I got some of the teaching points for you today. Yeah, so sweet syndrome is also called as an acute febrile neutrophilic dermatosis. As the name suggests, it's very acute in the context of ongoing fever with the presence of neutrophilic infiltration within the skin. And Sweet syndrome was originally described by Robert Douglas Sweet. And neutrophilic dermatosis, it's a kind of a group of non-infectious disorders visually characterized by the neutrophilic infiltration of the skin, which includes epidermis, dermis, or hypodermis, without evidence of true vasculitis. And it is usually characterized by the abrupt onset of tender plaques or nodules, as seen in this patient, with accompanying fevers, arthralgias, any ocular inflammation, and headaches. Sometimes atypical lesions do occur, which is characterized by the erythematous plaques, vesicles, and bullous lesion can also seen. So this is the classification of Sweet syndrome, where we do classical divide into three categories. Is it classical or idiopathic, malignancy associated Sweet syndrome, or drug induced Sweet syndrome? The most common, I would say in the bucket of the classical or idiopathic one, the post infectious like any respiratory infections or GI like Salmonella, Yersinia infections would possibly trigger the Sweet syndrome, and the IBD and other autoimmune conditions like rheumatoid arthritis, lupus, Sjogren's, Hashimoto's, Behçet's, dermatomyositis, and even Rabi mentioned it could also see in pregnancy too. And in the second bucket, the malignancy associated Sweet syndrome, interestingly, it can occur before or at the time or after the diagnosis of cancer. Sometimes in even some popular, especially in patients with MDS, Sweet syndrome could present as a paraneoplastic manifestation. And out of the malignancy bucket, 85% will come under the hematological cancers, mainly MDS, AML, CML, multiple myeloma, monoclonal gammopathies, and Hodgkin's, and 50% of salad cancers like breast cancer, GU, and GI cancers. And the other common bucket the Jazz was mentioning about the drug induced, the most common one is granulocyte colony stimulating factors. I think there are 20 case reports in the PubMed, which is published only about the GCF colony stimulating factors triggering Sweet syndrome, and tretinoin and trimethoprim sulfamethoxazole, bortezomib, and azathioprine. So this is the classification of Sweet syndrome. And coming to the demographics, it is usually 4:1. Usually, it's more common in females over the males, and typical age of onset is around 30 to 60. And the basic pathogenesis is basically a kind of hypersensitivity to the circulating bacterial, viral, or tumor antigens that is triggering all the neutrophils are coming into the skin, leading to the infiltration, causing Sweet syndrome. And what is the diagnostic criteria? We use again the major and minor criteria. Major criteria, the patient must have these two features to diagnose the patient as Sweet syndrome. What are those? The sudden onset of the tender, painful plaques and nodules, on neutrophilic infiltration in the dermis without evidence of vasculitis on skin biopsy. The minor criteria, the fever greater than 38.38 degrees Celsius, and the illness which is usually preceded by the respiratory, GI, or any associated with autoimmune condition, malignancy, or pregnancy, and the white count with neutrophilic predominance with elevated ESR, CRP, and other inflammatory markers, and the positive response to steroids. And the histopathology is diagnostic, and usually it shows the diffuse dense neutrophilic infiltration in the reticular dermis, and some kind of edema with dermal edema is seen, and without evidence of true vasculitis. And one of the differential diagnosis for Sweet syndrome is histiocytoid Sweet syndrome, which is one of the variant which includes the presence of histioid cells, which are immature myeloid cells, which are usually commonly mistaken as macrophages. And other differential for the histioid Sweet syndrome is leukemic cutis that Rabi was talking about. And this is the histopathological exam where you can see all the neutrophilic infiltration with all the dermal edema over here. And the final treatment is 2 to 4 weeks of steroids, usually starting dose of 40 to 60 mg. And sometimes you can also try intralesional corticosteroids, and topical steroids can also be used. And recurrence is common in up to 50% of the patients, most likely with an underlying inflammatory disorder or hematological malignancy. Thank you so much.
Wow, this has to be like the reference standard. Amazing. Prof, you're gonna say something too?
Dude, I was just gonna say, Raul, Robbie and I have had the privilege of being to so many national conferences and giving talks and listening to talks. This reminded me of like a great CPS at a national conference. Like, if I went to a national conference, this I think would be considered the gold standard. Well done.
Thank you so much, Reza. Thank you so much, Ravi.
Ashar, I know that there are very, very few people who would be able to step up to the plate after a performance like that, but I have no doubt that you can. I'm very, very excited for all the learning points that you have outlined here. Take it away, my friend.
Honestly, I'm not sure how to follow that. That was amazing, but let's have a crack at it. So, aside from the beautiful presentation that Rahul covered all of the pathophysiology of the teachings here, what I wanted to focus in our teaching points was the approach to a patient that is not getting better and the importance of re-evaluating our diagnostics. So the case has a focus on neutropenic fever plus, which is a great practice for clinical reasoning because it offers two choices. First, an emergency, and second, a process of constantly re-evaluating your patient. So let's start with that. A fever rarely presents as an emergency. There are two more prominent, very prominent cases, which is fever in a patient with cirrhosis and fever alone in patients with known neutropenia. In these cases, what you gotta do is collect whatever you need in the first 5 minutes and then start antibiotics ASAP. One great teaching that we discussed here was the choice of antibiotics and how do we think about the kinds of infections that can affect these patients. First is gram-negative coverage in everyone and gram-positive coverage based on the risk profile of these patients. Here, the first line thinking is the infections that may present on the body itself, and we're targeting organisms that are on our bodies. So, and second line, external elements, particularly TB and endemic infections, and reactivation of infections like Hep B. The second part, after moving on from the emergency, after we've stabilized the patient, is to see what else is going on. Especially in a neutropenic fever patient, what you need to find is a focus of infection, which requires a head-to-toe examination. And as Prof. has mentioned, every evaluation that you do is a spot evaluation. It's a snapshot of the whole picture, a picture that is developing. One thing to keep in mind here is that because of the neutropenia, the picture may not develop as we expected because many times what we see in the patients are a response of the inflammatory process. But here, one of the main legs of that process is gone, the neutrophils. So we need to keep that in mind as well and look everywhere to find the thing that we are looking for. One other teaching here is the value of antibody tests and serologic testings in this context. The immune system is gone, and we cannot find infectious processes or other things by looking at how the immune system is responding to it. There is no response here. And after that, we get to the nodular rashes before getting to the Soot syndrome part. What was interesting for me here was finding the center of gravity here. It's a systemic process, and the most likely cause here would be a metastatic process to the skin and dermis. And thinking at the pathophysiology of what we discussed up to this point, we have a few diagnostics. First is granulomatous infections. We had infections on our mind from the start, especially skin infections, because we can miss them in these contexts, and cancers, which are rare, but we are in a context that may be very likely because of the given history of leukemia. And Uh, this leads to the biopsy part that, yes, we were expecting a Switch syndrome hypothesis. We were working it up, as Rahul discusses, in acute febrile neutropenic dermatosis, which means if we biopsy these rashes, which is usually what we do when we see a rash, the findings may be unspecific, because we may see a neutrophilic infiltration, which may present in many other things. So we need to do a diagnosis of exclusion here. Again, a reevaluation of everything. We need to find a focus of infection in the lungs. We need to have a higher quality skin biopsy. And finally, we need to see if we have a response to treatment. Overall, just to summarize everything, when we're seeing a patient that is not getting better, we have three processes that we need to think about. A presentation of the old background diseases, an unrelated new process that we may not be thinking about because patients may have as many diseases as they like, and complications of what we are doing to them. Working all of these together, we need to have two lines of thinking. First, the emergency and treatment part, and second part, constant reevaluation of a spot evaluation. Every evaluation we do is a snapshot of the whole picture, and the picture may be developing as we are seeing the case. Thank you, Rahul, again for the great case. I learned a lot, and thank you for the great discussion.
Dude, Robbie, Khashar gave me goosebumps. I love the way that you set up the teaching points where you came all the way back to how should we approach that hospitalized patient with a new sign or symptom. That's just such high level teaching skills. And I'm just really blown. I don't get to hang out with you guys often. I come, once a week maybe, but I'm just so impressed with the growth I've witnessed. And maybe it's hard for Robbie to see that because he's there 8 days a week. I added a day for the days that he's there. But me coming in and just check, you guys are really the future of clinical reasoning and way beyond where I was at your stage. And I have no doubt that you guys are going to take it way beyond where Robbie and myself have taken clinical reasoning. Really good job.
Time to cash in those unemployment checks, huh, Prof. Rez? You ready?
Well, I do have a fork in.
Oh, you muted yourself right at the key.
Oh, I said I have a fork in the road. Elon Musk is offering me 8 months pay.
Oh, that's right.
Elon Musk, I like my job. Don't come after me. My name is Robbie. Yeah.
Oh, I don't know how to end the session after that, which is how we recently started an RLR session. So I will bid you all farewell. Bye.